I will be talking about a career in general practice. I think everyone has heard my introduction, so we'll move on. This just summarizes what Sid's already said. I'm currently redeployed to ICU at the moment because of COVID-19, but I would have been doing my general practice rotation with my academic ITP at the moment after finishing urology and ENT. So just a little bit about me. I was born in Scotland, lived there for about 12 years, moved to London, and I've been here ever since. I went to a small school in North London and City of London School for Girls, and I ended up going to St George's for my medical school degree. I also did a BSc in cardiovascular sciences because I was interested in cardiology and medicine at uni, so I went to Imperial. As you already may know what medical school is like, this is what it was like for me. And I did a lot of stuff within my medical school journey, joined lots of societies, worked as a peer skills tutor. So I taught to lots of the younger years, clinical examinations, communication skills. I ran mock OSCEs, revision sessions, conferences, TED Talks, participated in Teddy Bear Hospital, and also as part of the student union. So there's a lot around my actual work studying medicine. I think as you all may be in medical school at the moment, things are very different due to COVID, but when things do gradually return back to a new normality, I do highly recommend doing things outside of your course because it gives you a little bit more of a holistic idea of how things are in real life, and juggling different commitments, and it already brings that into you from a very early on stage of your career. A little bit about the NHS training pathway if you don't already know. Undergraduate, then you go on to do your foundation program if you choose to stay in the UK, that is, and then after that coupled uncoupled specialty training program. In between, there are a lot of options that some of you medical students may have already participated in. For example, doing a BSc. After your fourth year in some medical schools, you can do a master's. After you have graduated, you do the F1 and F2 as per normal. You have an option of doing an academic component, so that's the AFP. After that, a lot of people are now taking an F3, which is what I did, and you can do pretty much what you want in that year. So I worked as a clinical fellow. You can do something more academic, you can locum, you can travel, you can do further higher studies such as PhD or master's, if you didn't do that before, or you can straight go into your coupled uncoupled specialty training program. So I decided to do an F3 in surgery, mainly because I was considering a career in surgery or general practice, but I just wanted to make my mind up and use that year as a break. I mainly just taught medical students at Imperial. Got involved in a few medical education projects because I wanted to do medical education later on in my life as well. The only thing is I had to take a little bit of a pay cut because I wasn't doing as many, well, I wasn't doing any on-calls, but you still have the option to locum as an F3. So that will always be there if you do want extra money and you don't want to take that hit when you're taking a year out. The only thing I'd say is be careful depending on what specialty you're going to apply to. For example, surgery is a good one. If you are thinking of doing surgery, taking a year out needs to be quite a wise decision because they do look at why you've taken a year out, even though they have previously said that it doesn't matter. But actually in the applications from this year at least, they have looked upon it as to see why you've taken a year out. So it's quite difficult, but as a medical student, if you can start thinking about what your options are, if you have a particular location choice or preference, then the earlier you decide, the better. But saying that, you can change your mind anytime in your career. If I wanted to retrain in surgery later on, I think I would do that, but that just depends on you as a person and what your priorities are in life. So back to GP life. The GP training application has actually changed this year. It's become solely based on an examination, which is a combination of clinical questions, kind of similar to your final year exam, and also an SJT component, which also you do in your final year. So in a way, it's quite good. So keep all your notes from final year. Don't completely put them to the back of your head or throw them away because they do come useful. In stage one, you apply via Oriel, which is similar to what you will do for F1 and F2. When you start doing that, you'll get used to the system and how slow it is. But it is there for all of us to use, and It's something that you need to allocate good enough time. So always, for any application, once you start your postgraduate career, give yourself time for your application. Don't leave it to the last moment. You know, can't trust the system, and also there's lots of things to upload evidence-wise. So be very careful with that. So you need to have completed F2. It doesn't matter in what way of manner. You might have done F1, F2 being from here if you're international, or you've come, you know, from another job, then they still just need to see that you have got your F2 competency signed off, and you have to get your GMC registration. The examination itself is 3 hours. I think it's 3 hours long unless they've changed it. But I think it might be a bit longer now. They've put the SGD questions, more SGD questions in. It is something that is quite general and not very specific. So I think often people think that they need to study particular areas, particular topics, but it covers any specialty. Can have derm, pediatrics, obs and gynae, general medicine. There's a whole range of in it, and also your professional dilemma questions are quite particular, so doing as many practice questions are very important. Now, the key issue is that your whole rank is based on this exam. After that, you are then ranked from 1 to how many other people applied, and then you get allocated to where you want to be. The issue here is that no one interviews you, you don't do any form of OSCEs, there's no other assessment, so everything is just based on this one examination. Previously, as you can see, there was a similar long listing with a similar examination. This exam was sort of a first step to get maybe the top 10%, and they would straight pass on to getting their offer, and then they would rank their options and most likely get one or two of their top, either one of their top choices. And the rest would then go to the selection center to do a interview in a form of OSCE, but very, very basic, very, very basic, much, much easier than you would have, even easier than third year OSCEs. 3 stations and a written exercise, just looking at prioritization. Now that's obviously gone this year, but it may come back in the future. So it's very good if you can just keep on top of what's going on. I did the selection center with the interview, mainly because I applied for GP quite last minute. It's contrary to what I said, but I did a deferred entry. So I wasn't too bothered if I got a good choice or not, because I was hoping to reapply in my F3 year. But I managed to get a London offer, which was really good. And I just kept that in the back of my head and did my F3. Now, the interview, if it does come back in the next few years, it's just looking at key components in a good doctor. So you're empathetic, sensitive, good communication skills, clear, you can problem solve, and you maintain professional integrity that's based on your GMC guidelines. So there might be a station on confidentiality, might be a station on a colleague finding it difficult for whatever reason, and you have to sit and have a chat. It's quite straightforward. There's not a lot of testing. In fact, there's probably 0 testing of clinical management. So this is pure communication skills. Now, a little bit more about GP training. It's 3 years at the moment. So this is for an example from the East of England's GP post, but it's pretty similar across the country. So you start off with either a hospital job or a general practice job, and you rotate around. You might have 3 times 4 month posts, you might have a 6 month post, you might have 3 month posts. It just varies on, the deanery and what jobs they've given you. The key point is that you will spend 18 months in general practice. Now, this may change in the next few years. Your ST3 most certainly is all in general practice. So your ST1 and ST2 will have few hospital rotations, and then you go into ST3. After that, you're pretty much done. So the good thing about being a GP and training in GP is it's not as long as the other specialties. So you're pretty much qualified, before you're even 30, especially if you go straight through, or unless, you've done grad med, then it's different. The kind of rotations, there was a few mentioned in that previous slide, but here there's a whole range. So I currently have, and I've just finished urology and general surgery and ENT, and I will be moving on to general practice. Then next year I do have stroke and I've got public health. And it's quite good because I wanted a bit of surgery since I want to do minor ops, and I also wanted public health because I'm interested in that. So always look around in the different deaneries, because different deaneries have different types of jobs. Not all deaneries will have surgery, not all deaneries will have public health. So it's quite good to have a look around and see what would suit your interests. Like, I don't have any peds and obs and gynae. I'm okay with that because I did the GP in my F2 and I'm quite comfortable with the level of peds and obstetrics and gynecology. But you do need to realize that a lot of your general practice will include peds, obs and gynae, and psych, I would say. And knowing what's acute and what's chronic in terms of general medicine, A&E is also very important, because sometimes you have to ring the med reg and refer to them when a patient's just come to you for a routine appointment. So those, I'd say, are the most important rotations. The other thing to mention is not very well known, but there is also a 4-year GP training pathway. One's an academic clinical fellowship, pretty much the same thing. You do your ST1 to 3, but one of the years, extra years, you'll have protected academic time to do any research, any project. Quite flexible. You apply slightly differently. It's not the national process. There are jobs posted on Oriel and you apply via that. It is very competitive and you must have a little bit of research or academic interest from beforehand, but that shouldn't deter you anyway. It's worth applying if you're interested. There's also quite a unique opportunity to do global health fellowships. So again, some work similar to the academic clinical fellowship. You have 3 years, ST1, ST2, ST3, and 1 year extra where they fund you to go to South Africa or multiple other places that I've put here. It just depends on a yearly basis, and obviously due to COVID, things are a little bit different, but they still have managed to secure some posts, as you can see on my slides. This is from this year. And they also recommend you to do a diploma. Unfortunately, they don't fund this. So bear in mind that you would have to pay out your own pocket. And I've already mentioned there'd be a separate application. Now, the key reasons why I personally did GP is because I love medicine as a whole. I loved medicine during uni. I loved surgery before uni, and then I slightly got put off it during medical school, but then liked it a little bit more in F1 and F2, hence why I was considering it, but also really enjoyed general practice. In my F2, I had GP, surgery, and A&E because I particularly wanted all 3 of those posts to help me decide what I wanted to do, because I wasn't one of those who knew exactly what I was going to do. And it's important to realize that you're not always going to know what you want to do, and you might completely change your mind. That's okay. But the main thing that really attracted me to GP was the portfolio career. So these are just a few examples of what you can do after being qualified as a GP. So after my 3 years, if I want to do any of these jobs, I pretty much can pursue it at my own leisure. The difficulty is it's very based on your proactiveness and how much interest and how much effort you're going to put in. For example, if you do want to do a special interest, work in a minor surgery clinic, or you want to do some out of hours work, you need to organize your own experience. You need to do certain courses to fulfill that criteria. But all of that can be available during your training, with your educational supervisor. Again, similar to medical school, when you're on placement, you do get an educational and clinical supervisor. And, based on how proactive you are, you can interact with them and get all this information. But a simple Google search will show you what's out there. And more as the years have gone by, there is more scope for journalism if you're interested in that, because that was something I wanted to do. Media work, there's always going to be a need for doctors who want to comment, especially now since social media is a huge thing. But it is good once you've established yourself as a GP for a couple of years before you think about pursuing that. You can also work, for example, as a forensic medical examiner. You can work for a charity. There's lots of charities out there in humanitarian medicine that would love to have GPs and give up their time. Some of them might even pay if you're interested in getting extra money on the side. And the key thing to remember is, though, if you're going to do a portfolio career, it's less likely that you'll be a GP partner or even a salaried GP. Maybe you can negotiate. That is just full-time GP. That is not something that interested me, but for someone who loves GP, that is something you can do, especially if you've got an interest in business. being a GP partner opens a lot of avenues for managing your own business in a sort of way, because you're responsible for that whole practice and how your income and your outgoing expenses are all managed within that. Just to wrap up, tips for working as a junior doctor, just to know that all of these apply to everyone, doesn't matter what career, what specialty you're going to do. And this is going to help you build a good, strong base for when you start your specialty postgraduate training. So getting used to working with different teams, adapting, because you're still going to be rotating. Obviously, when you think about your long-term goals as a consultant or a GP, you do tend to stick to one place. But before that, a lot of your training and your youth is rotating around. So being flexible is really important. Learning and getting used to new experiences, those will stay for the rest of your medical career. You're going to be dealing with death. It doesn't matter if you're in primary care or secondary care. Accepting you're not perfect, because it doesn't matter what level you're at, you're always at risk of getting complaints and being sued. It's not the end of the world, but there's a way of dealing with it and just getting used to that and knowing when to ask for help as well. Being keen to learn, using technology, keeping up to date with research, all of this is super important. The only thing I'd say is try and broaden your experiences early on. I know it's hard, you've got a lot on your plate, even if you don't do it in medical school, but in your F1 and F2 years, you have plenty of opportunities. You have study leave, you have taster weeks, depending on the deanery. Ask them and make use of them, because it's, again, all dependent on how proactive you are. But take time out for yourself. Do something that is not medical, medicine related. That's the best way you'll concentrate on medicine as well as your life in itself. And just a few other things that I've mentioned that you can do, and you can do all of these, well, you have to do all of these in pretty much all of the specialty training programs. This is what you're going to be dealing with, as you already know, when you apply to medical school, but it does carry on. I know, even especially for GP, people think it is isolating. It can be, but there is a lot of teamwork within your own practice. And if you do choose to work in a hospital as a out of hours GP, or you work in a clinic, you will still be working with the team. So that will still always be there if you wanted to. This is why I advocate for GP. There is so much flexibility and ownership in the direction you want to take your career, and there's more scope for, less than full-time training, etc. Although I do think everyone should be pushing for that across all specialties, and I think maybe in the future that will happen. But that's kind of a quick summary, just to get it wrapped up within 10 minutes. If you do have any questions, there is the Q&A, so please ask questions then. I'll be happy to answer anything specific, and you can always reach out to me. Thank you so much.
Well, thank you so much for that, Dr. Juhee. Thank you for the insight into the GP pathway, and also tips for working as a junior doctor. So just a reminder, guys, for those of you who joined later on, we are currently having talks by our doctors, and we will then have our panel event where you guys can ask more general questions, and then we'll be opening up breakout rooms where you can ask specific questions to each of the doctors. Dr. Juhee will only be here until 7:30, so obviously if you want to speak to her, feel free to go to her breakout room first. But now, moving on, I would like to introduce Dr. Saga Sharma, who's a post-foundation clinical fellow in oncology based at the Leicester Royal Infirmary. He graduated from St. George's in 2018 with a BS in Global Health alongside his MBBS. He's starting the internal medicine training program next year, hoping to embark on a career in oncology. He has a keen interest in medical education and teaches clinical skills at St. George's. He's also a peer reviewer for the British Student Doctor and has multiple publications, posters and presentations. So over to you, Dr. Sharma.
Good evening. Can you guys hear me?
Yeah, we can.
Give me 1 second. I'm just going to find the PowerPoints. So yeah, you can see it. So as introduced, my name is Dr. Saga Sharma, and I'm working in the Leicester Royal Infirmary. Currently doing a year of work in oncology after completing my F1 and F2 years, which Dr. Juhee spoke about earlier. Kind of the 2 years you do after medical school, in which you get a variety of experience in different specialties, get a lot of exposure. One of the most important specialties, and a big specialty which people will go into straight after medical school, is general practice. The second most common one for people to go into is medicine. So medicine has around 3,000 training spots, 2,000 to 3,000 training spots after F2 year. And that's kind of the branch to all medical specialties, such as cardiology, oncology, respiratory medicine, neurology, the list goes on and on. So as introduced earlier, I'm interested in oncology, either medical or clinical oncology. I studied at St. George's like Dr. Juhee. I did an IBSc in global health. I'm currently working in Leicester Royal Infirmary. So just in terms of, to start with a little bit about the roles of a medical SHO. So what an SHO is an SHO is anyone after their foundation year 1. So foundation year 2, core level training, and until you become a medical registrar or a registrar in whichever specialty you choose to do. So your roles in kind of during medical training will be things like doing a ward round, doing ward work, clinics. These 3 things many of you guys would have already been to throughout medical school. Clerking in the acute units. So for example, the internal medical training pathway, which I'll go on to explain, has specific attachments in acute medicine, as that's an important role and an important specialty in the medical pathway. You'll also be doing night shifts. You're also given the chance to develop special interests. So for example, I had a job in oncology, which I really, really enjoyed. And throughout my F1 and F2, I've been involved in projects related to oncology, which are relevant to my further applications. You'll also be performing procedures. So during your F1 and F2 years, you need to get a number of procedures signed off. So cannulas, blood gases, venipuncture, which all of you have already done, I assume, in medical school. But going on further from this, as a medical SHO, you'll also be expected to do things like pleural drains, so chest drains, acidic drains and acidic taps and lumbar puncture. And those roles go forward even to the registrar level. And as an SHO, another big one of your big roles is to look after new doctors. So the F1 doctors who are coming onto the wards, you kind of look after them. You're also involved heavily in teaching medical students, for example, bedside teaching. And part of your role becomes more and more involved in kind of working with allied healthcare professionals. And initially, as an F1 and F2 doctor, you're mainly ward-based, but throughout going higher and higher, you kind of work with the other teams as well, like when can we ensure this patient has a safe discharge, and going on to think about those things. Now, in terms of the internal medicine curriculum itself, there are 2 groups of specialties that you can go into, the Group 1 and Group 2 specialties. Now, after your foundation year 1 and 2, you apply to IMT, so internal medical training. Now, your internal medical training can either be 2 years or be 3 years. If you want to do a Group 1 specialty, your internal medical training is 3 years. If you want to do a Group 2 specialty, your internal medical training is 2 years. So there's a difference in terms of the length of training. This list is also constantly being changed. So for example, intensive care medicine is now a Group 2 specialty when you do it on its own. So you can do it after 2 years of internal medical training. Now moving on to the next slide. So this is kind of a slide looking at the training pathways for Group 1 and Group 2. So now looking at your Group 1 specialties, you've got your foundation years, so your 2 years that we've spoken about already. And you've got your MRCP and your 3-year internal medical training curriculum. So your first year is IMT1. Essentially, you have 3 4-month jobs, one of which has to include geriatric medicine. Your IMT2 is 3 other medical jobs. And one of those jobs has to include intensive care medicine. And the IMT3 year, which is a recent addition to the curriculum as of 2 years ago, you're kind of a junior medical registrar. So you're kind of getting used to the more senior levels of care and more senior decisions that medical registrars make. And during your IMT, so your 3 years, you're expected to complete the MRCP, which is the membership of the Royal College of Physicians exam. So that's 3 parts. You've got part 1, which is kind of your clinical sciences, so 1st and 2nd year of medical school. Part 2, which is kind of clinical medicine, so that's more looking at diagnostics and treatments. And part 3, which is PACES, which is an OSCE, which is often quoted as the most difficult part. Now, going on after this, so for your group 1 specialties, you go into your specialty training. So usually it says indicative 4 years, but some specialties have 5 years. So if you're looking at a group 1 specialty, you're kind of looking at 2 + 3 + up to 5 years. So you're looking at around up to 10 years before you become a consultant in that specialty, which is a big contrast to what Juhee mentioned earlier in terms of general practice, which is 3 years after your foundation training. But with the group 1, you get dual CCT. So what CCT means is your certificate of completion of training. So you're certified in general medicine plus whatever specialty you do. So for example, if you picked cardiology, you'd be general medical CCT plus cardiology CCT. Now, just a little bit about the group 2 specialty pathway. So one of the reasons I picked oncology specifically as a specialty is that the internal medical training pathway is only 2 years rather than 3 years. And I really didn't want to do a year as a medical registrar, which to me kind of was off-putting. And plus oncology is mainly outpatient based. You do inpatient work, but you have a good mix of outpatient and inpatient work. And your total training is 2 + 2 + up to 4 years. So can be a year or two shorter. Now, moving on to kind of what you need for career in medicine. So medical jobs during your F1 and F2 year. So looking at all the jobs available to you when you rank them, trying to rank ones with more jobs in medicine if you're interested specifically in medicine, trying to get a variety of specialties in there is always useful. So now the scoring system, what medicine does is it scores you on all of these aspects here. So undergraduate degrees, postgraduate degrees, prizes, presentations, publications, developing a teaching program, quality improvement projects, and leadership skills. Now, looking at this slide here, so in terms of the scoring this year, they've changed things because we can't run interviews. So your verified self-assessment is all of the aspects in the previous slide, which I'll go on to talk about. But your application form contained, so in terms of your commitment to specialty, communication, CPD, self-reflective practice, and teamwork, there were 5 200-word boxes on your application form in which you outlined why are you committed to medicine, what's good about your communication skills, where have you shown continued professional development related to medicine, give me an example of self-reflective practice, and teamwork. Normally, all of those aspects would be assessed in the interview, but this year they had 5 200-word boxes to kind of assess it through an application form, so it was a bit different due to COVID. Now, moving on to your self-assessment, these are all the things you score for. So if you do an extra intercalated degree, if you get a first, you get 6 extra points. If you're a postgrad student, you get 6 points for a PhD or 4 points for an MSc. So for example, if any of you have done an intercalated MSc, that's great for points. You get points for any prizes during medical school or as a junior doctor. The most come for a distinction at the end of medical school, so that would be 6 out of 6. You get 4 points for a merit. Presentations. So now they're very, very specific about the criteria for full points here. So you get most points for an oral presentation in which you are first or second author at a national or international meeting. Publications, up to 8 points. Make sure they're all PubMed cited. That's where the most points come. So a lot of journals may not be PubMed cited, so it's always useful to check before submitting work to them. Teaching programs, so you get up to 6 points there. The most points come for designing and organizing multiple sessions over a 3-month period with feedback, and using kind of well-tested feedback mechanisms is always useful. So the Royal College of Physicians has a kind of feedback form which you can use. You also get points for a teaching qualification. So If any of you have a master's in teaching, which I doubt at this stage, I didn't have one, many people don't, you get up to 4 points, but there are other online courses you can do. Now QI, so quality improvement, you get 8 points for doing 3 cycles of a QI project with data analysis in each cycle. Again, if you're very smart in what you do, your QI can be 8 points, and you can present it for up to 8 points as well. So using the same evidence. And finally, leadership skills. So you get up to 6 points. You get 6 points for 3 months of national or regional leadership levels. So for example, if any of you are in your British Indian Medical Association committee for over 3 months, that's kind of showing evidence of regional leadership for more than 3 months, for which you would get 6 points. Now, just to go very quickly through these two slides. So advice for medical school, everything from the previous slides apply. I don't want to keep repeating myself, but I would always do an intercalated degree. Although it doesn't count for foundation year points, it always counts further down the line when you go to apply for registrar jobs, when you go to apply for a consultant job, it really, really counts a lot. Get involved in audits, quality improvement, and research. I know this sounds very tedious, but I always like to find out where the project is actually going, because sometimes a lot of projects get started and then get lost in the air. So always find out whether this is publish worthy, whether this is going for a presentation or a poster. And as I mentioned earlier, always look for opportunities in publications, preferably PubMed indexed, because you get a lot more points for PubMed indexed ones, 8 points as opposed to 2 points. And all the university societies that you're involved in, I'm sure a lot of you are involved in various committees, all of that does count in terms of regional leadership and even local leadership, for which you get points at. So develop those leadership skills through that. Now, for your foundation program, a couple of other bits of advice. Remember, the first thing now, you're actually a doctor, so you can do a lot more things. A lot more people trust you rather than being a medical student on the wards, with things like data, with projects. Make sure you have medical jobs. Get extra skills signed off. For example, in your F1 and F2, if you've done an LP, get it signed off, get evidence for it. Get involved in medical student teaching. Now, this is really, really easy. There are always assistantship students looking for somebody to mentor them, and the medical school often contacts F1s and F2s, and that's already a couple of points because you've taught a couple of sessions over a 3-month period for that student. Get involved in projects, as I mentioned. Publish, again, which I mentioned. Finally, leadership skills. So there's very easy ways you can get involved in leadership skills at at a local and regional level as a foundation doctor. So you've got your doctors' mess committees, your local doctor training committees, and you can even become local BMA rep. So all of these aspects count for points, and constantly also look on the website. So the website for internal medical training is imtrecruitment.org. Have a look there. The scoring criteria constantly changes, but I hope I've provided a good overview so far. And thank you very much.
Yeah, thank you very much, Dr. Sharma. One sec, we're just going to go back to here. And now we're going to have Dr. Danny Chandler to talk about surgery. So Dr. Danny is an academic foundation year 2, currently working in trauma and orthopedics at University Hospital Coventry in Warwickshire. He has a BSc interdisciplinary science from University of Leicester and graduated with MBCHB from University of Warwick in 2019. And he's now pursuing a career in trauma and orthopedics. He's completed MRCS Part A and is in the process of applying for core surgical training / improving surgical training in trauma and orthopedics. So.
Hello, I'm just going to get my presentation. Can everyone see the presentation?
Yep.
Yep.
Okay, so my name's Danny. I'm one of the academic foundation year 2 doctors in Coventry. I'm also an honorary research fellow at the University of Warwick at the moment. I'm currently in my F2 year, and I'm applying for surgical training this year, and have applied for a number of different surgical jobs, including run through orthopedic training in Scotland, the academic clinical fellowship, and CST and IST, as you've just been told. So just about me, I'm a F2 interested in trauma and orthopedics. As you've already been told, I've done a BSc before starting medicine, and then I went on to do graduate entry medicine at the University of Warwick. I currently work at UHCW in Coventry, which is the second biggest, well, not biggest, second busiest major trauma centre in the country. And I'm applying for surgical training at the moment. So just about medical school. So like I said, I went to Warwick Medical School as a graduate. So the structure was slightly different. But I think hopefully you'll see them, just look at just the list of things that are some of the things that I've done. That is very similar to what my undergraduate colleagues have also been doing. So unlike it being 5 or 6 years at medical school, I only did 4 years at medical school. In that first year, it was mostly just lectures and case-based learning discussions with an examination at the end of the year. Year 2 was a little bit different. So we had lectures for the first half of the year, and then it was full-time clinical placements from then on. And during that time, we also had to do a SSC module, where you would either undertake a piece of research work, an audit, or a service evaluation type QI project. So that in itself was a good starting point to get the whole QI machine working. I was quite fortunate in that my audit had pretty good outcomes, and I was able to present that at the Association of Anaesthetics and Anaesthetists of Great Britain and Ireland's trainee meeting in 2017. And I also managed to get a publication for a full cycle audit completion out of that too. During my second year, I'd also done an additional medical education project looking at virtual patients, whether students could create virtual patients for other students to learn from. And that I was fortunate enough in that included an exchange with medical students at Monash University in Melbourne, Australia. So that was something quite good to get involved in. And throughout both phase 2 and phase 3, I've also been a peer support and student seminars teacher, which are peer-to-peer teaching initiatives run at the University of Warwick. During my final year, I undertook a surgical elective in Sri Lanka, that was in 4 weeks in total at the hospitals, 3 weeks in general surgery and 1 week in orthopedics. And I've also been involved in multiple other projects at medical school. So that was medical school, and then so I'm in the middle of my foundation program now. So I applied for the academic foundation program, which is there's two academic programs. There's two foundation programs you can apply for. The regular foundation program, which everyone applies for through Oriel in medical school. There's also an additional academic foundation program for those who are keen in either research, education, or leadership. Different areas and different deaneries do different academic programs, but these are separate application forms that you'd have to fill in. And you can only apply to 2 deaneries for the academic program. These applications differ to the regular foundation program in that they have these white space questions, similar to the medical applications you've just heard about, where you essentially have a certain number of characters to explain and answer the questions you have. So I got awarded the Trauma and Orthopedics Academic Foundation Program in Coventry in the West Midlands Deanery. What that means is that I have 2 placements in trauma and orthopedics, 1 clinical and 1 academic. The academic one is the job that I'm doing at the moment. And for my first year foundation program, I had general surgery and was supposed to have general medicine, which would be diabetes endocrinology, and I was supposed to have respiratory medicine. However, due to the COVID pandemic, my respiratory placement got cancelled, and I was made to do an extra 4 months in general medicine at UHCW. In that time, I've managed to get involved in a few audits and closing. So During the foundation program, you're expected to complete one QI project. It's usually an audit, and that's part of the sort of sign-offs and portfolios that you have to complete in that first year, and also in your second year too. During my time in orthopedics, I have been involved in a research project and completed one clinical audit. And during my academic block at the moment, I'm now actually involved in 8 different projects at the same time. So during foundation program, there is a lot of scope to do a lot of these things, of extra things that can get you points on applications. So just going through the surgical training pathway. So the surgical training pathway is similar to the medical one. The medical one changed recently, but the surgical one has for now stayed the same. So you complete your undergraduate medical training at medical school, and you go into your foundation program, whether that be the clinical foundation program or the academic foundation program, and you do your F1 and your F2 years. As my colleagues have said, it's becoming increasingly more common for people to take a year out at F3 year. So that can be wedged in between this foundation program and then the specialist surgical training. Surgery has a number of routes into it. So you can do the uncoupled route, which is your core surgical training, or CST 1 and 2. That's a 2-year program, which provides a balanced surgical curriculum, allowing you the skills to apply to any of the other surgical specialties for specialty training at the ST3 level. There are also run-through posts available. Certain specialties have more run-through posts than others, and there is also this new pilot scheme called Improving Surgical Training, which also provides coupled run-through programs, currently in general surgery, urology, vascular, and trauma and orthopedics. Scotland run things slightly differently. They have run-through programs for orthopedics and a couple of the other specialties, which is separate to IST, and they have separate application forms. All of these applications are made through Oriel, which is a system you'll come to know very well. Whether you like it or not, that's a completely different story. But the process itself has changed over the last sort of 12 months because of the COVID pandemic. As you heard from my previous colleague, the medical training, they're not doing interviews this year. Well, for surgical training, interviews are still happening, but they're happening virtually via Microsoft Teams. But the process essentially is that you submit the application form, and there's roughly around 2,000 people that apply for surgical training. Well, this is for core surgical training. The other things that I've applied for have lower numbers, but the competition for places is a lot higher. For core surgical training, the application form is usually filled in and submitted by the end of November. Now, this doesn't include any white space questions like the medical one does this year, because they've still planned to have interviews. The initial plan, they had 2 plans, Plan A and Plan B. Plan A would be the interviews going ahead as they are at the moment, and Plan B would be just based on your self-assessment scores, which are the scores very similar to in the medical applications. If you meet their sort of minimum self-assessment, you get invited to submit evidence in their portfolio station, which used to be a part of the interview, but is now a separate online portal. And that happens at the end of December, start of January. And at that point, the 2,000 applicants gets whittled down to about 1,100. After you get your evidence gets submitted and they verify it, and then they'll give you a score based on that. And that number then drops to about 950. With then those being invited to interview. The interview consisting of 2 stations. One's a management station and one is a clinical station. And then after interviews, offers get made to the 600 or so people they're offering core surgical training jobs to. Now, last year, that number was 607, I think. So it's just over 600. So once you get to the interview stage, generally the odds are pretty good, providing you're prepared. Now, the things you score points for are exactly the same as for the medical ones. The only caveat to that, I'd say, is that non-PubMed citable research or papers or publications get no points. Everything that's published has to be PubMed citable for the surgical applications. So this is the current list taken from the Royal College of Surgeons of England website of the surgical specialties: general surgery, urology, vascular, trauma, orthopedics, ENT, max facs for which you need a dental degree as well, cardiothoracics, neurosurgery, pediatric surgery, which the application for pediatric surgery is the same as the CST application. However, there is an option when you get an offer to apply for pediatric surgery as opposed to any of the specialties and plastics. Now, the majority of these also have academic clinical fellowship positions, which are here, which is denoted by these stars. So these are research-based posts, usually funded by the NIHR, and generally there are 2 entry points, either at ST1 or ST3. If you enter it at ST3, generally it's coupled with a run-through training post, so you become a junior registrar in that specialty and move up without having to apply for a national training number. So these are the things that I would say that you'd have to do to get a career in surgery. So you'd have to, I mean, surgical electives are not essential, but if you're thinking at this stage that you want to do surgery, it's best to do a surgical elective, because this is points on the application form that you just can't get after you leave medical school. And it's 4 points this year. So it's quite a big chunk of points. Surgical courses, again, you can, so these you don't necessarily have to do at medical school, because the majority of courses you have to do are when you become a clinician. It's like the basic surgical skills course, or ATLS. But there are surgical skills for students courses that you can attend, which also count towards your applications. When you become a junior doctor, doing the examinations as early as possible, I would recommend. Getting involved in all the audits and projects you can, because at the end of the day, publications are points, and you have to provide evidence that you've also participated in QI projects. And then I think the most important difference between surgery and all the other specialties is that you need to keep a log of all the procedures that you're involved with. So if you're in theatre and you're assisting at any point, make sure you log it in your logbook. And the logbook that most people use, which is sort of recommended by the Royal Colleges, is this one, the e-logbook. There's a pan-surgical logbook. You can sign up as a medical student. You don't need a GMC number to sign up, and then you can start to log from medical school and keep the same logbook all the way up to consultant. So even consultants log all their procedures. So what does a surgical SHO do? Well, during my time on orthopedics, we would have a trauma meeting in the morning, or a handover meeting on the other specialties, where we get handed over from the night shift if you've been on call. Otherwise, you would start with a ward round. You would then continue the ward round after the meeting otherwise, and do ward-based jobs, and that involves interacting with all the other allied professionals and sorting out scans and all that sort of stuff. You get experience in clinics. So I was looking during orthopedics, I was given 1 morning a week where I could go to fracture clinic, and I would clerk patients myself. Well, not clerk, I would see patients myself, come up with management plans, dictate letters, all under the supervision of consultants and registrars. You have on-call and night commitments. If you work in a major trauma center, you'll also get trauma calls if you're in general surgery and orthopedics. And get to theatre as much as possible. Like, you're allowed to go to theatre. Most consultants and registrars want you to go. If you're interested, they're more than happy to teach you stuff. You can get involved. As an F2, I've managed to do a few procedures myself under supervision of a consultant and a registrar, and been able to log that in my logbook, and that looks good as well, because those are supervisor, trainer scrubbed logs to put in. And also get involved in audit and research projects. So these are just a few of the things that I've done so far over the last 2 years. So I logged over 50 cases as supervisor training scrubbed or assisting on my logbook, done MRCS Part A, done a few courses, got involved in a lot of research projects. I've started working towards a medical education PG cert, which gives you extra points on the application. And I've also done a leadership course, which is available on the NHS Leadership Academy website, the Edward Jenner program. So, I mean, the things to do during med school and as an F1 and F2 are largely the same as what my colleagues have said. Just get involved in everything as much as you can. A good way to get PubMed citable publications at med school is to publish letters and case reports. They count towards your foundation application. not so much going forward, but they're just an extra thing to have on your CV. And I think it's really important to look a stage ahead. So if you're applying for foundation program and you know you want to do a career in surgery, look at the core training person specification and what they're looking for, so you can start ticking off the boxes now, essentially. And again, it's very similar for what you would do during the foundation program. So I know we'll leave all the questions till afterwards, but that's just an overview of surgical training and the roles of a surgical SHO.
Thank you so much for that, Dr. Danny. I'm sure everyone found that really, really useful. So now moving on to Obs and Gynae, and we have Dr. Juhee with us today. She is someone who is deeply passionate about patient education and women's health. She believes in empowering patients to be confident and knowledgeable about their conditions, building physician-patient relationships and improving patient outcomes. She was born in India, did her schooling in Dubai, went back to India for med school, and then did her residency in Obs and Gynae. And then she moved to the UK on a Royal College Fellowship, after which she worked in the NHS for 3 years. She's now moved back to Dubai, so not a conventional doctor for sure. However, her experience in the UK has given her a good insight into the training system here. And so she hopes to inspire some future Obs and Gynae doctors tonight. Over to you, Dr. Juhee.
Hi, Punya. Thanks so much for the intro. Well, definitely not your conventional doctor. I think all my colleagues earlier are trainees there locally, but let's hope I can add something today with this presentation. So I'll just share my screen, bear with me. So life as an Obs and Gynae doctor, it definitely has its challenges. I can honestly say I truly love what I do. I mean, just think about it. Where else in the hospital are people excited and happy to be admitted other than our labor wards? So we were at the second slide. Have a good look at it. I find it really interesting. I mean, it's very hard to choose what specialty to go ahead for. According to this diagram, to be in Obs and Gynae, basically you need to be a bitch who's average academically, who goes off no sleep, who thinks kids are all right for the first few minutes of life, you know. But I'm hoping to demonstrate that Obs and Gynae is much more than that. So why Obs and Gynae? For me personally, I was sure I wanted to do something which had more hands-on practice. I don't think I could be stuck for hours on a ward round or chained to a clinic all day. So choosing a specialty that involved some operating was really important for me. I'm not saying those things are wrong, but if you're someone who likes to, you know, be on the go, maybe Obs and Gynae is definitely for you. You won't be bored working in Obs and Gynae. Each day you see and learn new things, and genuinely, no 2 days are the same. No two women are the same. So having said that, if variety makes you anxious, there's plenty of opportunity to subspecialize and then sort of settle down in your field, like urogynae, reproductive medicine, gynae-onc, maternal fetal medicine, and the list goes on. We'll talk about that a little bit later. I appreciate that MDTs, so multidisciplinary teams, are key to all medical and surgical fields nowadays. But I really feel Obs and Gynae gives you a true opportunity to work in a truly multi-professional team on a day-to-day basis. I mean, take our labor wards, for example. We have midwives who take responsibility for and ownership of their patients, anesthetic and neonatal colleagues. It is a very sociable specialty. And especially after coming to the UK and working in the NHS, I completely second that. Now, if you're a good communicator, Obs and Gynae is ideal for you. I think it is one of the most important traits that you need to work successfully and safely in this specialty. Not just because of the team nature, but because of the fact that you're dealing with patients in one of the most stressful and acute situations. They're scared, they're in pain, and there's a baby involved. So I think it's all about communication when it comes to our field. I feel Obs and Gynae is a very, very rewarding field. I can honestly say that so far, I've not had a single day in specialty training when I've woken up and not wanted to go to work. I mean, I've probably attended like at least 500 to 600 birthdays, but every birthday is still special. Again, the vast majority of our outcomes are positive, and people really appreciate what you do. As a rule, our patient population is quite unique compared to medicine and surgery, because largely most of our women are actually healthy. They're not patients as such. Sometimes they do get unwell and things don't go really straightforward, which presents as a challenge. But we've also got plenty of older women, and when it comes to urogyne and gyne-onc, there's a lot of variety. Now, coming to the challenges, I think this field is a little bit emotionally demanding. When you have a challenging case, like in any other field of medicine or surgery, you do take things home. And it's sort of difficult to leave those feelings and emotions, they're all a part of you. But I feel, in general, it is a very happy place to be when it comes to obs and gynae. Now, going down to what a typical week would look like in a registrar's duty. Of course, because of COVID, things have changed slightly, but typically you'd have clinic days, you would be on a labor ward the next day and on call. You'd be attending like an A&E for pregnant women, that's the obstetric assessment unit, and you'd have gynae placements also, surgery and things like that. Looking at our on-call system, it's generally 1 in 8. With obs and gynae, I think it's a very well-supported field. So me being an outsider, I've done my basic training in India. I was very well supported, and it's not just about me. I think all junior doctors were very well supported by the consultant. They're generally resident consultants until the afternoon, sometimes on nights. So good support all throughout. This is just, I've just picked up a very useful image from our Royal College website, which talks about the basic training years. I think all of that is pretty similar to what my colleague earlier mentioned. But talking about what you can specialize in further, we have acute gynae and early pregnancy. We have benign abdominal surgery, both open and laparoscopic, benign gynae surgery, colposcopy. We have medical education, menopause, oncology, pediatric and adults in gynecology, sexual health, and subfertility and reproductive health. You don't necessarily need to go for any of the subspecialties. You could just specialize in general obs and gynae and have your field of special interest.
Sorry, Dr. Juhee, I'm going to have to interrupt you there for a second. I think your slides aren't changing.
Oh.
Yeah, so you're on our screen, you're still on slide 2. I don't know if you're meant to be on a different slide.
Yes, definitely. I've gone through 4 slides now, so let me stop sharing again. Wow.
That's all right.
No problem.
Whatever you said made sense. I think it's just the slides weren't changing for some reason.
Sure. Can you see a different slide at all now, or?
No, we can't see a presentation yet.
Okay, just bear with me. I apologize. Maybe what you could do is I'll share you my whole presentation and then share it with all the students who've sort of joined us, if that makes sense.
Yeah, that should be fine. Okay, yeah, we can see you going through the presentation now.
I think I'll stick to this. I'm not going on to the presentation mode. Maybe that's what's getting things stuck.
Yeah, maybe if you try that.
Yeah, are my slides changing now?
No, I think it's frozen again.
Yeah, the issue was even during the login, I couldn't log in through the app. So I've logged in through the browser. Maybe that's what's causing all the problems. Basically, I've logged in from another part of the world. Yeah. And I mean, it shouldn't actually interfere with logistics, but what I'll do is I'll share the slides with you guys. I think it has frozen on the most interesting slide, so I don't mind. But the others have a few details on what are the training system involves, the education program, and certain resources from the Royal College. I was basically getting to that. So do you think it's a good idea just continuing and then we could share the slides later?
Yeah, no, that's completely fine. What you can do is you can carry on. And I'm just going to check if Sid has your presentation and perhaps one of us could share the screen.
Sure, yeah. I had emailed it to one of you guys, so
okay. So yeah, if you carry on, and I'll try to sort that out with him.
Okay, definitely.
Okay, all right.
Okay, so I think we'd spoken a little bit about how the different kinds of specialities that we have in obs and gynae. I was getting to the fact about what would help any one of you to actually go ahead and specialize in this field. So like my colleagues mentioned earlier, getting all your F2 competencies signed off, all of that stands. I don't want to repeat everything, but definitely audits, looking at getting things published in specifically in the kind of field you're interested in always helps. The RCOG has very good career days. And I mean, of course, thanks to the pandemic, things have changed slightly. And the last one we had was actually in Feb 2019, but fingers crossed, we're probably moving to more virtual career days. So they're free for all junior doctors to attend. And I would encourage each one of you to attend that. I mean, and go ahead and find out more of what this exciting field actually holds for you. So just to summarize, I'm not sure if we've got a hold of the slides yet, but
yes, we do. So if you stop sharing screen, and Sid's going to start sharing his screen, if that's okay, and then you can just let him know when you want him to change the slides.
Sure.
Sid, let us know when you're ready. There we go.
Fabulous. Sid, if you could please jump onto, yeah, that's perfect. That slide's perfect. So I'll just talk through this slide again, guys. It's what a typical week would look like for any gynae registrar junior doctor. Outside of COVID, things were slightly different, but during the pandemic, we've sort of cut down on elective gynae surgeries. But as you can see, you'd have clinic days, you'd be on call on the labor ward. The obstetric assessment unit, where some of you might have already worked as F1s or F2s, is basically like an A&E for pregnant women, which is very, very exciting. And then you'd have teaching days, and then of course, elective gynae surgeries or gynae oncology and gynae clinics. Could you please go on to the next slide? So we're looking at our on-call system, and I spoke to you guys about the good support we get in this field. Definitely, I mean, I'm sure all fields are well supported, but even as an outsider coming from having been trained outside the country, I came in and I found really brilliant support from my seniors and consultants and everyone. There is also generally lots of backup. Like I've suggested, like I've said, there's a two-tier system, so that really, really helps. Next slide, please. Okay, so this is the RCOG matrix of how the training goes ahead. And then I did mention the TSMs that you guys can do. I will share a link about all those details with you later. But next slide. These are the resources, and I spoke to you about the career days and the training days and stuff. But just to summarize very quickly, I think there are definitely challenges. I mean, work-life balance can get difficult in a field like this. You do have to go on a little bit of less sleep, like I discussed earlier. But for me, the positives definitely outweigh the challenges. And of course, with the support of family, friends, and colleagues alike, I think I've been able to pursue this career alongside being a mom and being a like an IMG, international medical graduate. So definitely, I would recommend obs and gynae to each one of you. And next slide, please. I think I've shared my email address. And if you guys want to follow my journey, I've also started writing on Instagram, because that's one of my patients today suggested. So definitely look forward to sort of hearing from all of you. And if not, we can always catch up in Dubai for a post-COVID party sometime.